Assalamualaikum.
Waalaikumsalam.
Ya ni saya tak boleh apa nama on video saya ni. Dia kata host disable. Kena kena able dulu.
Sekarang boleh tak?
Okay, saya try.
Okey.
Alright, okay. Sebabnya buka sangat ni. Okay, gambar okay.
Oh. Okey, nampak okey.
Alright. So, saya try share screen je. Okay, kan nampak tak?
Okey,
Jap,
boleh nampak.
nampak Alright. Saya try kejap ya. Kadang-kadang bila tekan slideshow ni dia tak tu tahu dia tak dia tak gerak. Gerak tak?
Ada.
Nampak tak outline of discussion ke masih front page?
Nampak outline of discussion.
Nampak
Nampak.
Dia gerak slide sebab tadi kadang-kadang saya buat dia tak gerak
Dia gerak.
okey.
Nampak okey lah. Nampak semua.
Alright. Saya punya slide ni itulah kita punya masa 8:30 sampai
Sampai basically sampai 9:05 atau 9:10, lepas tu kita open Q&A.
so about dalam half an hour 40 minutes lah kan.
Betul.
So saya kena cepat jugalah sebenarnya. Slide ni
Eh,
banyak juga ni. Sebab dia kata common upper limb fracture. Tapi tak apalah, nanti kita tengok macam mana lah. Tengok macam mana.
ah,
Ni apa Afiq
Betul betul. Sekejap
Ha.
ni.
Awak kat mana sekarang ni? Afiq Amsyar. Dah ramai yang masuk ke belum lagi?
Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Uh, I hope everyone can hear me. Now to the first. Boleh dengar suara saya?
Saya boleh dengar.
Alright. Okay. So tanpa membuang masa, insyaAllah pada malam ni kita akan uh, meneruskan dengan sesi CME MedTweetMy yang seterusnya. Uh, So, a very warm welcome to each and every one of you to our webinar, which actually for this week we are focusing on the topic that actually quite close with healthcare professional with title of common upper limb fracture. And my name is Mohamed and I'm honored to serve as a moderator for tonight's sessions. So, as we know, fracture affecting the upper limb represent a significant portion of injury which is accounted in uh, clinical practice. So from simple fracture to as complex as trauma, the management of this injury actually demand a very comprehensive understanding of anatomy, pathology, and of course with different treatments modalities. So today we gather visually to explore on this. I believe is a crucial aspect of the orthopedic care with the aim to enhance or refining our knowledge and clinical skills. So throughout this webinar, we'll be having Mr. Mahyuddin, experts who will share his wealth of knowledge, experiences, and perspective. And of course, we will explore various aspects of upper limb fracture, including belief, epidemiology, mechanism of injury, of, as well as diagnostic approaches and also various treatment strategies. So, uh, without further ado, I believe our speaker also, our panel is already here for quite some time. So, I Dr. Ahmad Mahyuddin, dengan segala hormatnya saya persilakanlah untuk memulakan sesi pada malam ini. The floor is yours.
Okay, bismillahirrahmanirrahim. Alhamdulillah Rabbil Alamin. Wassalatu wassalamu ala asyrafil anbiya wal mursalin wa ala alihi wa sahbihi ajma'in. Okay, thank you very much, Dr. Afiq, for your kind introduction. Okay, I would like to welcome all of you to our session today. So far, I think if from what I can see, we have about 107 people who joined us today. Just a bit about myself before I proceed. I will be giving a talk on common upper limb fractures. Okay, this topic is very important, and I think it involves all of us. We need to know at least some basic about upper limb fractures wherever we working, whether in the clinic or in the hospitals, or either we are in the private sector or in the government sector. I think we need to know some basic about upper limb fractures so that if we encounter these issues or this problem or this diagnosis, we can straight away refer the case to our orthopedic colleagues. Okay, just about a bit about myself. I'm the head of department in Hospital Kemaman Orthopedic at the moment. For the past 3 years. Before that, I worked in Hospital Temerloh for more than 11 years, still in the government sector. And so far, I like this place so much. And I would welcome all of you. If you want to come to Kemaman, please give me a call. I would like to make this session interactive, not in a way that you speak, but I would like you to share or to answer in the text box. Okay. Whenever I ask question, please reply so that we can benefit this session, okay? I have about 50 slides or so, just to touch a bit on a few conditions or a few fractures of the upper limbs. And we have about 40 minutes. Okay, we have about 40 minutes only, so I'll be fast. But please respond so that we can benefit this session. Okay, this is my hospital. Yeah, on the upper left corner is my current hospital. If you can see from our on the right lower side is the new hospital. The new hospital will be open in 2 years' time. It is a 300 bedded, and it is situated in Kijar, Kemaman. So about 10 minutes drive from the current hospital. So please do come and visit us in new hospital. All right. Okay, this is the outline of my discussion. So when we talk about upper limb, it will come from the shoulder until the hand. Okay, we have shoulder. I'll be talking basic, yeah, basic. So I hope this session will benefit our housemen and also medical officers. If there are specialists here or you are, consultant, please enjoy the session. Maybe you can refresh your memory about orthopedics. Okay. Okay. So I'll talk about the upper limb. Upper limb includes our shoulder, our arm, yeah, our elbow, forearm, and also wrist and hands. So those are the upper limbs. Okay. I'll talk about each session and touch maybe one or two common fractures involving that region. All right. Okay, basic about orthopedics. When we talk about orthopedics, when we examine patient, there must be three. Always there are three. First, look, feel, and move. So you must not exclude any of these steps. You must see the patient, you must feel the patient, and you must move the limb if it doesn't cause any pain to the patient. All right. Basic number two, reading the x-rays. So there are some rules on reading the x-rays. Remember the rule of two. Okay. So two views, two joints, two limbs, two injuries, and two occasions. Two views, AP and lateral, is compulsory for all upper limb fractures. Two joints, meaning what? When we have fracture of the humerus, we need to include the joint above and below the shoulder and the elbow joint. Similar to fracture of the forearm, you need to include the elbow and the wrist. So it's compulsory. So, and every time we examine patient, we have to be systematic. Must see the patient as a whole, examine the soft tissue, the bone, and the joint. When we talk about the bone, you must always mention about the site of the fractures. Yeah? Where is the fracture? Whether it's intraarticular or extraarticular. Okay? And we need to have some knowledge and know how to describe the fracture configuration. Whether it's a fracture is complete or incomplete, so that when we talk, we sounds like a doctor. Okay, so we know what we are talking about, so we can talk on the same language. All right, so this is the basic number three. Basic number three, always we have issues with housemen. So when we want to teach our housemen to correctly make a diagnosis. So this is the sequence. When we say, first you have to mention about the fracture, whether it's open or closed, the fracture configuration, and then the location and the bone. Finally, we have the classification of fractures. Not all fractures have classification that we have to remember, but there are some common fractures that have classification. It's good to have classification so that we know when we talk, we are talking about the same language. We know when we want to study, we want to do a study, we know what type of classification that we want to do. All right. So, for example, when we have a fracture of the radius, we have, first we mention about whether it's closed or open. We mention the configuration of the fracture, spiral or oblique fracture. So you can jumble this box here. You can always mention open, spiral, fracture. Yeah, this is the end of the right humerus, for example. Okay, so this is the sequence. This is the sequence. You can snap this picture. All right. Okay, first we go about our shoulder. Okay, our shoulder. For all the region, we need to know the age of the patient. Why? Because some patient, if they are old, then we need to bear in mind about osteoporosis. When they are children, we need to know about Salter-Harris classification, about the growth plate, So we need to know, maybe it's not maybe it's not a fracture, maybe it's a growth plate. So bear that in mind. Okay, this what I can see from this picture. Okay, can anyone type on in the chat box? Okay, 91-year-old, right shoulder swelling for the past 6 months. What comes to your mind? Anyone would like to answer? Maybe I give 20 seconds or maybe 15 seconds if anyone want to write your answer on the text box. Okay, come on. We have 148 people here. Anyone want to attempt? Left shoulder, lower compact, right shoulder dislocate. Okay, neglected fracture or dislocate. All right, good. Okay, very good. Okay, so definitely we can see. Thank you very much for those who are responding. I appreciate that so much. If you write, you will benefit from this session. If you don't write, then rugi. So please participate. Okay, please participate. So if you see from this picture, you can see about the swelling of the right shoulder. It can be easily mistaken for a tumor, but you have to examine the patient. So, okay, very good. No sinus discharge around swelling. Okay, very good. Okay, okay, okay. Next, compulsory to do X-ray. Okay, it's compulsory to do X-ray. So if you can see from this X-ray, definitely there is a shoulder dislocation. Okay, shoulder dislocation. So this shoulder is dislocated, whether it's anterior or posterior. Anyone want to give a guess? Interior or posterior? Anterior, posterior. Okay, interior. Okay, so majority is anterior. Okay, if posterior, you will see a light bulb sign. Okay, this is anterior shoulder dislocation. Okay, anterior shoulder dislocation is very common. 97 of cases is anterior, 97%. So commonly is anterior. If posterior is about maybe about 2 to 4% only, it's very, very low. So usually it's how does it happen? It's a blow to abducted or extended shoulder, externally rotated. Usually, if someone wants to play, badminton or tennis, so that's when if you have a trauma at that time, then it's easily dislocated anteriorly. Okay, so what you have to do, you have to examine the patient, whether there is a sensation loss or not, whether the patient can touch the opposite shoulder or not. That's usually the test that you can do. Okay. Okay. What about this picture here? What can you see on this picture? Okay, light bulb. Okay, very good. Okay. So what about this picture? Anyone wants to give a guess? Okay, very good. Okay, very easy, okay? Okay, orthopedic is very easy. If you know how to read the X-ray, do you think there is a fracture over the head of the head of the humerus? Anyone wants to, whether there is, it's not ossification, it's a growth plate, it's a growth plate. Okay, growth plate, a physis or a growth plate. Okay, so this case is a clavicle fracture. Okay, clavicle fracture. Okay, the full diagnosis is a fracture middleton of left clavicle. I don't say open or close because I do not know whether it's open or close. You have to examine the patient and see whether there is a wound or not. Only then you can say open or close. Okay, this is a fracture middleton of left clavicle. So for this fracture, you have to examine and make sure there is no subclavian artery injury. So you have to palpate the vessel, the pulses, and you have to make sure there is no brachial plexus injury. Okay, so over the mid-shaft of the clavicle, we have our subclavian vessels and also the brachial plexus running inferiorly. Okay. Okay, for clavicle fracture, usually mainly the treatment is conservative, yeah. Usually we just use the arm sling, okay. But there are some cases where we do operation. For example, if open fracture cases, if we have a tinted skin, yeah, it's a very sharp edge pointing, or maybe there's a, you know, if we see the fragment is pointing towards the lungs. So maybe those cases, maybe we need to do operation. Or some cases, we end up with non-union. Okay, sometimes we have non-union of the clavicle fracture. We may also want to do internal fixation, okay, depending on the fracture. Okay, now we go to the humerus. Humerus, similar like shoulder, we need to know the age of the patient, the anatomy, and possible associated nerve injury. Okay, what comes to your mind? We are talking about humerus, so definitely you know the diagnosis already, okay? But what we know from this patient, you need to examine the patient. Open the upper limb. You see there is a bruise over the lateral aspect of the left arm. So please examine the patient. Maybe it's a closed fracture, but it can also be an open fracture. So please examine the patient. Okay, anyone wants to give a guess or wants to have a try? What is your diagnosis? What fracture is this? Okay, head of humerus fracture. Closed fracture. Okay, we do not know whether it's closed or open. Oh, yeah, we know because we saw the wound just now, right? There's no wound, eh? Okay, so it's a closed fracture. Very good. So closed fracture. Okay, neck of humerus. Okay, surgical neck of humerus. Well done, well done, well done. Oh, I love this. Thank you very much. That's very good. Okay, for this type of fracture, we need to remember there is a nerve at risk. Yeah, what nerve? Axillary nerve. Okay, axillary nerve. So axillary nerve, everyone knows what the sign. Yeah, the sign is regimental badge area numbness. Yeah. So regimental badge 2, what is regimental badge? It's the badge over the okay, very good, Mohamed Amir. Yeah, loss of regimental area, regimental badge, loss of sensation. Yeah, loss of sensation. So dekat kita punya right shoulder, usually where we have a badge of a sergeant, okay, that's your regimental badge. Okay, and sometimes if we have a motor part of the axillary nerve injury, then we may have a deltoid muscle wasting as well over long term. So that is very important to examine, touch the regimental badge area. If there is axillary nerve injury, then we need to document. Axillary nerve is very thin and very small. Very small. It's about 6 centimeter from the tip of the acromion. Very about. When we open the shoulder, lateral approach, we can see the axillary nerve wind around the neck of the neck of humerus. Okay. Okay. Now, what about this picture here? This is easier than the previous one. Okay, what is your diagnosis? Where is the fracture? Okay, Rohaidah Rosli, mid-shaft humerus fracture. Yes, very good. Okay, very good. All right, very good. Okay, you can say whether it's mid-shaft or junction between mid-shaft and distal third of the right humerus. Okay, I love all of you. Very good. Very active. Very good. I do not know whether you are housemen or medical officers, but this is how we want our officer to be. We have to be active. We have to be interactive. Okay. So please, as always, similar like the proximal part of the shoulder just now. For mixed shaft, there is a risk of radial nerve injury. Radial nerve injury. So if you have radial nerve injury, ankulated. Okay. So we have a wrist drop. We have a wrist drop. So please examine the patient whether patient have wrist drop or not. Okay. Okay. Wrist drop. Usually, if we have over the humerus, it will comes together with the finger drop as well. Wrist drop and finger drop. If only finger drop, usually the fracture over the posterior interosseous nerve, over the radial head. Okay. There's a lower injury. Okay. So please examine the patient. So humerus fracture, it's not, it's only about 3 to 5%, but high risk of non-union, about 33%. So for some patients, usually we try to attempt a close conservative management. But for some patients, we may need to do internal fixation. For example, fracture for non-union, floating elbow. What does it mean by floating elbow? Floating elbow means the elbow is floating lah. Floating, meaning we have fracture of the humerus as well as the radius and ulna. If we say floating knee, there is a fracture of the femur and the tibia. Okay. So another indication is obesity. Obesity. Why? Because if patient is obese, the arm is so big, you cannot hold the reduction with your U-slab. So we may need to do internal fixation. So there's an issue with obese patient. Yeah? So try to counsel patient. If possible, if before we have any injury, try not to get obese. Yeah? Obesity is associated with so many medical problems, right? Okay, so we ourselves must show a good example as well. Okay. All right. Okay, next slide. Okay, elbow. Elbow. What's the time now? Okay, elbow, similar, but there is some addition. For elbow, we need to know the fat pad sign, the teardrop sign, in order to know whether there is a fracture. Teardrop, this one is anterior fat pad sign over the anterior part of the distal humerus. And we have a posterior fat pad sign. Usually, posterior fat pad sign is pathological. Anterior fat pad sign could be normal, okay? Okay, this 11-year-old boy with a motor vehicle accident, yeah? So what, it's not easy to see, but I think, okay, what can you say from this X-ray here? Anyone wants to give a try? Close fracture supracondylar, okay. Supracondylar humerus, okay. Fiza, humerus, don't forget your humerus. We can have supracondylar femur, right? So supracondylar of the humerus. All right. All right, okay. Very good. Okay, this is the knowledge pearl that I want to share. Okay, supracondylar humerus fracture is associated with median nerve injury. Yeah, not ulnar nerve. Ulnar nerve usually we have iatrogenic injury. Usually we have injury of the ulnar nerve during the operation itself. Yeah, during the pinning of the or K-wiring of the supracondylar humerus. But during the initial trauma, the injury is for onto the median nerve. Okay, and we have to always remember there is a risk of brachial artery injury as well. Okay, this one not that common, but you have to examine the patient. Sometimes we have a pink pulseless, yeah, what we call pink pulseless, or maybe pale pulseless. Yeah, so it's an emergency. Okay, very common. Supracondylar humerus fracture in children. About 90% of children, we see this almost every week in our hospital, right? So please bear in mind, examine the patient. You need to master the X-ray for this type of fracture. Okay. Okay, management for grade 1, we have, I don't go in details because we don't really have time. But for grade 1, which is undisplaced fracture, yeah, we do conservative management. Just maybe a full length backslap in 90-degree flexion of the elbow. But for type 2 and 3, usually we go operative. Yeah, for the operation, we can always discuss further whether we want to go, yeah, want to do a two wires, lateral or medial lateral, or a combination 2 and 1 wire. So there are many options depending on the fracture configuration and also surgeon preference lah. Okay. Okay. Okay, radius and ulnar fracture. How do I go about time? Okay, kan? Okay, radius and ulnar fracture. I will touch maybe two over the mid shaft of the radius and ulnar. I think all of you should know about this fracture. Okay, what fracture is this? Fracture mid shaft of the left ulnar. Are you sure, Nur Ain Lokman? What bone is this? Xing Yung Lee. Radius fracture. Okay, Sakina radius fracture. Okay, very good. So this here, this our radius. This our right radius, yeah. Okay, this right radius. Okay, proximal radius. What else can you see on this X-ray besides the fracture? Anything else that you want to comment on? Volar displacement. Okay. Galeazzi, Shu Yu Chiu. Very good. Okay. Yeah, this is a Galeazzi fracture. Yeah? Galeazzi fracture. Galeazzi fracture. Okay, Galeazzi fracture. Galeazzi fracture is a fracture of the distal third of the radius with distal radioulnar joint dislocation. Okay, if we see back the X-ray here, there's a fracture distal third of the radius. This radius, this end of the radius, there is a this subluxation as well. It's not normal. We'll go about the I'll share about the parameters of the distal radius after this. Yeah, why do I say this is not normal? Okay. But Galeazzi fracture is a fracture that we need to identify. You must not do CMR and CAS as a definitive management. Yeah, because for Galeazzi fracture, it's compulsory to do internal fixation. Yeah, we need to plate this. We need to plate this. Otherwise, patient will have issues with movement, rotation of the forearm lateral. Okay. Okay, please, please, we need to, I think tonight, please, you take one of the take-home message, please identify Galeazzi fracture and its cousin. Yeah? This is the cousin. Okay, this is the, what bone is this? What bone is fracture in this case? Sakinah Ahmad, Alna, Nurin Sofia. Okay, very good. Monteja, no, Amalina, go step further. Monteja fracture. Okay, very good. Very good, Amalina. So there is a Monteja fracture. Monteja fracture is the fracture of ulna with radial head dislocation or proximal radioulnar joint dislocation. Okay, similar with the radius, it's compulsory to do internal fixation. Must not treat conservatively as a definitive management. Compulsory. So must refer this case to tertiary center and must be fixed. Okay, remember that. Okay, wrist. Okay, this is the parameters. 8:57. Okay, almost 9 o'clock. About 10 minutes lah. Okay, 10 minutes. InsyaAllah, I'll cover the case lah, our topic. Okay, the wrist. Okay, the wrist is a bit more complex. There are three parameters that usually I want my houseman or medical officer to remember. Why? Because it is compulsory to know in order to decide whether we can treat this fracture operative, conservative, or we need fixation, open reduction and internal fixation. So usually what we see radial inclination. Okay, this is the radial inclination. First, we draw a line, over the distal of the radius, and we make another line and angle there until the tip of the radius styloid. Okay, this is the radial height. The one over on the right color is the height of the radius. Okay, I will share the parameters after this, and the volatile from the lateral view. Okay, these are the three parameters. Okay, diagnosis assessment. This is a close. There's a fracture of the distal radius. We're talking about the distal radius. Fall on outstretched hand. Fall from bicycle. Okay. Okay. Can we accept this X-ray or not? When we say acceptable or not acceptable, meaning if it's acceptable, then we can treat this fracture conservatively, meaning we can just apply a cast. We don't have to do any surgery for this case. Okay, unacceptable, Marina. Okay, very good. Okay, it's not acceptable. Okay, this case is not. Why it's not acceptable? Other angulation. Okay, Mohamed. Okay, other angulation. Okay, there is an angulation here. So it is not acceptable. Okay, this is an extra articular fracture. It doesn't involve the articular surface, but there are some parameters as well. These are the parameters of the shaft of the distal or distal third of the radius. Okay, there are some degree of angulation that we can accept depending on the age of patient. Yeah? Okay, let's say the patient is less than 9 years old. Okay, our patient just now is 11 kan, 11 or 12, something like that. Okay. So if less than 9 years old, we can accept up to 30 degrees. Why? Because we have remodeling of the bone. Okay, that is why we can accept a higher degree of angulation. But if the patient is more than 9 years old, yeah, maybe 10 years old and above, then the degree of angulation that we can accept is lower, right? So over the shaft is only 10 degree, but over the distal part is 20 degrees. Okay. Okay. Rotation is not acceptable at all. Okay, please remember that. Rotation is not acceptable at all. Okay, this is the fracture of the distal end of the right radius. Okay. Okay, what about this X-ray? Who wants to try whether it's acceptable or not? Okay. Siti Zulaikhan, Zulafzan, Siti Zulafzan. Okay. Muhammad Amir ada angulation. No of, no of apa ni? Pendek tak potong. Okay. Acceptable. Okay, acceptable. Semua acceptable. Arvin, acceptable. Afika, acceptable. Semua nak accept ni. Acceptable. Okay, I share another slide. What about this one? If you see this, we have a 7. Radiohead. Kat mana Radiohead ni? Suvar Nisha. Okay, we don't have the Radiohead over the distal. The radiohead is over the proximal radioulnar joint, not over the distal radioulnar joint. Okay. Reduce radial height, Amalina. Okay, yes. Okay, we have 7-11 rule. 7-11 rule. Look at this. So, acceptable parameters, radial inclination about 22 degrees. Yeah, volatile 7 degrees, radial height 11 degrees. We have a range. But just to make it easy to remember, we have a 7-11 rule. 7-11 tahu kan? Kedai 7-11. Senang ingat kan? Okay. Radial height 11, volatile 7 degrees, radial inclination 22. 11 times 2, 22. Okay. So radial height ni, we want radial height to be about 22 degrees. Yeah. If we see back the X-ray just now, this radial height and the radial inclination is less than that. Yeah. It's almost flat. Yeah, it's less than 22 degrees. The radial height is lost as well. Radial height maybe about 2 to 3 millimeters. Yeah, so it is not acceptable. Okay, it is not acceptable. Subanisha, okay, typo radial height. Okay lah, acceptable. Acceptable. Your typo is acceptable. Okay, all right. What about this one? Give it another try. Whether this one is acceptable or not. This one not acceptable lah. We already have the parameters. Okay, this is not acceptable. One, we lost the volatile, and D is ulnar plus. Oh, no Amalina ni orthopedic MO ke ulnar plus? Okay, and we have a intra-articular involvement. Intra-articular involvement. Okay, this is not acceptable. Okay. So that's why for some cases, when it's not acceptable, let's say when we have attempted CMR, close manipulative reduction, and it's not acceptable, then we need to go for internal fixation. For some fractures, intra-articular fractures, definitely we need to do internal fixation, unless patient have some medical problem that make it impossible to do surgery. Then maybe we have to accept that, especially old patient. If we have fracture like this, but patient is already 70 years old, or maybe 65 and above, 70, the demand is not that much, non-dominant hand, patient not really in favor of doing surgery, then it's okay. We can just put a cast. Even for some fracture, like Colles fracture in osteoporotic bone, we do not to do a full length cast. We can apply a below elbow cast. Just a below elbow cast will be is sufficient. Okay. All right. What is this? Anyone wants to give a guess? Balsimran Kaur. What about this one? Amalina, what about this one? What fracture is this? Is it similar like the previous one? Or is it something else? Not acceptable. Also not acceptable, I think. Okay. Okay, you are right. Not acceptable. So what fracture is this? This is Salter Harris, Nur Ain. Okay. Torus fracture, Amalina. Okay. Good attempt. Very good. Cool. This is a Salter Harris fracture. Fracture involving the growth plate. Yeah. Salter Harris type 2. Lawrence, Anthony, very good. So the most common Salter Harris fracture is Salter Harris type 2. Yeah. If you can't remember, yeah, we have about 5 lah, Salter Harris. Not sure lah which one. Okay, you can say the most common is Salter Harris type 2 lah. Yeah. The most common is Salter Harris type 2. So this is a fracture distance of the radius, Salter Harris type 2, right? Okay, what is Salter Harris fracture? This is Salter Harris fracture. Salter Harris fracture, we have fracture involving physis or growth plate in children. So do not mention Salter Harris in adult fracture. Okay, it's only for children or maybe teenagers with a growth plate. Okay. Okay, so Salter is a fracture through the physis. Yeah. I don't really like the word above or below or because sometimes you may be mistaken. Above for your proximal femur, distal femur is not similar with above of proximal tibia. It's different. Yeah? So the best way to remember is to know your part of the bone, yeah? Whether it's physis, epiphysis, or metaphysis. Yeah? So if fracture type 2, meaning fracture of the physis and the metaphysis, it goes into the physis. If type 3, it involves the physis and also the epiphysis. Epiphysis. And type 4 involve both the physis, metaphysis, and the epiphysis. And for type 5, we have like something like compression, erasure of the or crush of the growth plate. It's not that common, not common. But please examine the patient. Why? Because if that patient have significant pain or tenderness over the that joint, please look hard for fracture. Or maybe for some patient, we may need to treat as if there is a fracture. Yeah, even though it's not very clear, but we treat as a fracture. It's not better to overtreat than to undertreat. And what you can do if let's say that boy is just maybe 10 or 2 years old, 3 years old, you can always give a appointment in a week or maybe 2 weeks and repeat the X-ray. And if there is a fracture, then you will see some callus formation, a soft callus formation. Okay, what about this one? What about this one? I just have a few more slides. What about this one? Anyone wants to give a try? Do you see any fracture or what do you see in this case? Terry sign, Evelyn. Okay, metacarpal bone seems displaced. Suvarnisha. Okay. Anyone else? Terry what? Evelyn. Scapholonic dissociation. Okay, Lawrence. Very good. Okay. Okay. Anyone else wants to try? Terry Thomas sign. Okay, very good. Scaphoid fracture. Okay, very good. Very sharp eye. Very good. Scaphoid fracture. Shohaida. Okay, very good. If you are not sure, you can always ask for scaffold series. Okay. Scaffold series. This is a Terry Thomas sign. Terry Thomas sign. Yeah, periodic dislocation. Okay, very good. For those who answer just now. Siapa jawab tadi? Terry Thomas. Mohamed. Syuju pun betul. Okay. Suhaida. Okay, very good. Okay, so it's a Terry Thomas sign. So this is a normal, this is not a normal X-ray. Please make sure if we have X-ray of the wrist, you need to remember. Yeah. One of the issues is we do not know the bone. Okay, we do not know the bones of the carpal bones. We do not know. Yeah, we have 8 carpal bones. We have 7 tarsal bones. Okay, sometimes it's not easy to remember. This is a normal X-ray of the carpal bones. Okay, we have 8 of them, and there are some spaces, yeah, in between the proximal row and also the distal row. This is a normal appearance of the wrist. Okay, If we have something different from this X-ray, then it is abnormal. Yeah. Look at this. Yeah. Look at this X-ray. Okay. This X-ray is so crumpled. You don't see a space between the bone. Okay. So if we have fracture or something like this, then you please repeat the X-ray. Yeah? Do a scaffold series. Yeah? Then you can see a bit more detail. Okay. This is the scaffold series. Yeah? Okay. So this the answer for this, I don't ask question about this one, maybe a bit more difficult. Okay. We have scaffold fracture and perineal dislocation. Okay. Scaffold fracture with perineal dislocation. Okay? Over the left side ni lah. The right side ni normal X-ray. Just to make just a comparison. Yeah? So we have fracture over the scaphoid and also the perineal dislocation. Then we have a triquetrum fracture. Can you see the triquetrum fracture? Not easy lah. Yeah? Susah sikit. It's okay. Okay. The hands. So we comes to the end. Okay. Oh, just on time. Very good. We have 40 minutes. Okay. The hands, similar like the rest of the bones, you need to know the bones. One thing that I want to mention here is please use the right terminology. Yeah? Thumb, index finger, middle finger, ring finger, and little finger. Okay. Jangan guna kadang sebut tak betul kan. First finger, fourth finger, yeah, second finger. So please use the right terminology. We have index, middle, ring, and little finger. Okay. Okay. Anyone wants to give a try the second last X-ray? What can you see from this X-ray? Look hard. Okay, look hard. Anyone wants to try? Shuhaida, Nomalina, Lawrence, Z Yung Lee, dorsal displacement of the IPJ of index finger. Wow, okay. Subluxation IPJ, distal index. Okay, Nur Silmi. Anjay, very sharp eye. Okay, very good. Okay, very good. Okay. Congratulations for those who attempt. Okay, very good. Cool. So this is a fracture tip of the distal phalanx, a tough fracture. Okay. So it's not easy sometimes. So please make sure you have to determine the type of the injury that patient has, examine the patient, and from there we can focus when we do X-ray. Okay. Okay. What about this one? This is the last X-ray. Mallet finger. Oh, little finger mallet. Okay. Okay. What about this one? What do you think? It's a very interesting X-ray. Anyone wants to give a guess? What is the metal? A ring. Okay, Zulafzan. Chin Chin. Using Yuli. Okay, Chin Chin. Lot of the ring, A ring. Okay. Okay, right ring finger. Screw. Wow, Shifa. Wow, screw, Okay. Okay lah. Okay, there's a ring lah actually, So this one, just want to mention, please do just not look at the X-ray. Please examine the patient. Otherwise, you will miss the bone that's stuck in your little finger. Okay, please examine the patient. Sometimes when we are on call, just our houseman just text WhatsApp only, we just see the WhatsApp picture. We don't really look at the patient. We don't examine the patient. When the ED call us, we don't examine the patient. We just look at the picture only. So that's not good. Very, very dangerous. And we need to remove the ring. Yeah. Sometimes it can cause congestion and we can lose the ring finger. Okay. Make sure remove the rings. Yeah. Remove the wood there. Yeah. And then debride or do a washout. Yeah. Or maybe toilet and suturing. Okay. Okay. This is my take home message. 9:15. So we have about 15 minutes if you have any question. First, if there is no tenderness, usually there is no fracture. Okay. In order to have a fracture, usually there will be a tenderness over the side of the limb. Okay. So if there is tenderness, please look at more than once. Examine the patient again until you sure where there is no fracture. Maybe it's soft tissue injury. Okay. Know the normal anatomy. It is compulsory. Yeah? We need to know. It's not just for orthopedics, even for general surgery, medical, pediatric, I think, or ONG, we need to know the anatomy. Yeah? If you want to further your studies, we need to master your anatomy. Yeah? Know the normal healing process. Why? Because we need to know when the callus form, yeah? When the bone will heal, when the soft tissue will heal. Okay, we need to know the healing process. If you are not sure, please consult. So this is the most important thing lah. It's okay to ask. It's okay not to know. Yeah? Jangan malu. Just ask lah. It's better ask rather than we cause harm to our patient. Okay. All right. I think that's all. My slide for tonight. I'm so glad we can finish on time. If you have any question, you can ask. All right. You can write. Okay. In Montegia fracture, why the main treatment is oral? Is it applicable for both adult and children? Yes, Nurin. Yes, usually if let's say we have Galeazzi or fracture of the radius undisplaced. If the fracture is undisplaced, then it's okay. We can apply cast. But if the fracture is displaced, it's compulsory to fix. Yeah. Otherwise, the fracture is unstable fracture. Even we can say is a we call it a fracture of necessity. Yeah, fracture of necessity. Galeazzi and Montegia fracture is compulsory to fix. Otherwise, patient will lose function. Patient will not able to pronate and supinate the forearm. So when in orthopedic, we talk about principles, principle of management. If we have abscess, we need to drain, meaning antibiotic is not sufficient. We need to do incision and drainage. That's the principle. Unless patient is moribund or patient is, can't do much for about patient, then it's okay. But if there is no contraindication for surgery, then we need to go in. We need to remove the, take out the pus. If there is a fracture, intra-articular fracture, involve the joint, then it's compulsory to do, it's compulsory to restore the articular surface. This is the principle. Yeah? So for each and fracture, we have a principle. The principle, how much angulation we can set, how much displacement we can set. So for fracture of the Galeazzi and Montegia, is compulsory to fix. That's the principle. Okay. No such thing as silly question. Bal Simran, you can ask. Grade 4, is it crush? No growth plate. Okay. Grade 4, we have a crush. Harris type 4, we have a crush. Type 4, sorry, type 4 is not crush. Type 5 is crush. Type 4 is through the physis, metaphysis, and epiphysis. Okay. For crush, what will happen? We have a growth arrest. Growth arrest. So we have disturbance of the growth of the articular surface because it's crushed, damage. So we have a crushed articular surface. So yeah, the growth plate is there, but it's crushed. So usually it will not grow. Then we have a shortening of the limb. Yeah, we have a shortening of the limb. Okay. All right. Any more question? For those patients, we need to go, maybe need to refer to PITS, orthopedic stuff. Maybe we need to do lengthening. Yeah. All right. Normally the upper limb, how long we cast? Okay, how long we cast? Okay, very good. Good question. Shu Yu Chiu. Okay. The answer is depends on the age of patient. Depends on the age. Pediatric patient also. That's why my one of the take-home message number 3 is to know the normal healing process. We cast the patient until callus formation. Yeah? Once the callus has formed, usually the fracture will not displace anymore. Then we can remove the cast and we can start movement of the joint. Yeah? we must not delay removal of the cast. If let's say, oh takut lah, I'm afraid lah to open this cast nanti fracture in this space. But if the callus is already there, then it's quite safe to remove. Yeah. If you delay the removal of the cast, then you may cause stiffness of the joint. You may cause muscle wasting. Okay, you may cause further problem later on. So please we need to know the normal healing process. Okay, to answer the question, for upper limb, for adult, usually I take about 6 weeks for callus formation, adult. But for children, half the time. 3 weeks of the cast, start movement. Yeah. Even supracondylar humerus fracture, K-wiring, 3 weeks, remove the wire, start movement, range of motion. Okay. Distant radius in children, remove the wire, 3 weeks, start movement. Adult, 6 weeks. Not less than that. If less than that, then patient need to know the fracture may displace. For upper limb, for the lower limb, a bit longer. Yeah. I'll take about 6 to 8 weeks. 6 to 8 weeks lah. Plus minus. We need to do the X-ray and see the X-ray. If there is callus formation, then we can remove the cast. Start movement. Yeah. If let's say it depends on the site as well. Let's say tibia fracture. Usually tibia fracture will take slightly longer time because of the lack of blood supply. Sometimes we need a longer time. So rather than apply a full length cast, you can cut the cast shorter into a PTB cast, patella tendon bearing cast. You can allow patient to move. Yeah. By doing that, you can allow movement of the joint, the knee joint, and only immobilize the ankle joint. So that's one of the ways to prevent stiffness. Bear in mind, for some patients, we have a delay healing, fracture healing. Why? Diabetic patient, immunocompromised patient, smoking. Yeah, smoking is very common in our country. So for those patients, it may take twice as long, or maybe thrice, or maybe even longer than that. So please, that's one of our problem lah. We need to remember patient not to smoke. Cakap at least jangan rokok lah, dah baik nanti barulah risau rokok. Tapi kalau lah turun berokok lagi bagus. Okay, jangan risau rokok lah. Okay, doctor, if I'm in district setting encounter assaulted Harris with displacement in the middle of the night, should I just CMR and put on back slap and refer auto during the TCA, or should I just refer? Okay, let me think. If you know, or you have you know how to do CMR, and you can do a repeat X-ray, it's okay. You can do CMR if you know. That's not wrong. Yeah. But if you are not sure, or if you are in doubt, you don't have the expertise, then you can just apply the back slap. Yeah, apply a back slap and refer the case as soon as possible. Must refer early, less than 1 week. Yeah, early. If in children the callus formation is very fast. Soft callus, 1 or 2 weeks we have some soft callus already. Yeah? We need to see the patient early to do CMR. Okay, all right. Thank you. All right. 9:24. 9:24. Please fill in your attendance
Sama, I
e-certificate.
think there's another question in
Okay.
the Q&A chat box.
Apa soalan what? I missed that one.
Yeah, can explain the difference between torus and green stick fracture.
Torus and green stick. Can torus fracture? Macam mana? I don't have a picture lah. Torus fracture, easy way to mention torus is just a buckling of the cortex. It just susah tak ada gambar. It's just a buckling tau. Dia macam if we have a straight line, then it's just macam terbonggol sikit macam tu. Okay, it's a buckle. Torus, buckling. Green stick means green stick tahu green stick. Green stick is kita punya batang pokok yang belum tua tu, yang muda tu. So I explain in Malay. Kalau kita ambil batang pokok ranting tu, kita patahkan dia. Okay, one side of the batang tu dia akan terbuka, but the other side tu dia still intact. So dia tak, it is not fully fractured. The fracture is incomplete. It only involve one side of the cortex. Okay. Why? Because this one only occur in children, yeah? Green stick fracture. Because the apa? Periosteum. Yeah? Periosteum is very thick. So we don't have a complete fracture. So that's the answer. Yeah? Macam batang muda lah. Batang muda. Okay, right. No Silmi, welcome. Mashita, welcome. Thanks for everyone. Thank you everyone for joining our session tonight. Okay, I hope this session will benefit. Let's see lah if MedTweetMy wants me to give another session on the lower limb. Boleh lah. Dapat raya ke. Okay, alright. Certainly. Okay lah. Boleh lah after raya lah. Kita bagi peluang orang lain dulu. Alright, thank you very much. End of posting. Siapa? Muhammad Syahrul Nizam. End of posting apa ni? Houseman okay lah. Good luck for those houseman, medical student. Okay. Stay strong, medical student, houseman, stay strong. Stay strong, insyaAllah lah. We pray for the best lah, for our profession, insyaAllah. My CPD dapat. Alright.
Thank you, Mr. Ma.
Okay. Welcome. Nanti jumpa
Okay,
lagi Okay, right. Assalamualaikum.
for the session. So I hope everyone can get a lot of new information with regards to limb fracture, and insyaAllah kita akan cuba arrange untuk lower limb fracture sometime soon. Mungkin macam Mr. Ma cakap tadi, mungkin lepas raya lah.
InsyaAllah.
So yeah, we are able to conclude and finish on time, and all the questions in the Q&A session were answered by Mr. Ma. So thank you again, and thank you for all the participants. Well, from here I can see we are actually close to 200 attendees lah today, which I believe all are interested and very active in participating in the discussion. So dia bukan one way communication lah, dia multi ways.
I love that. Yeah. Macam tu bagus.
Yeah. So alright. So I think that's conclude our session for tonight. So I hope we can see everyone soon again in another next hour's MedTweetMy CNE session. So with that, I end the session with Tasbih Kifarah dan Surah As. Okay.
Okay,
So
thank you
with
very
that,
much.
thank you.
Have a good
Thank you
night.
everyone.
Okay,
Alright.
bye-bye.
Assalamualaikum.
Salam.